everybody, thank you for coming along today to one of our series of finance webinars from Phil Harnby, who's our partner accountant. My name's Helen Murray. I'm the National Account Executive for FPM Group and mainly help practices with training needs for the practices in the PCNs and ICBs. We also offer first practice management and all of our compliance tools and my surgery website. So I've just come along today really to introduce Phil. You can see Phil on the screen there, and one of our training managers, Jerry, who is also here, if there's any questions you have about training at all. But the one thing that I wanted to mention was that we, following on from the free webinars, we do have some relevant workshops relating to PCN finance and another one called Maximising Achievement of the IIF. So, you will learn some things about those today, but if you would like more information and to attend a half-day workshop, then you can get in touch with us and I'll send you some information about when those courses are due to run. I will stay on the call, and after the questions and answers, if anybody wants to ask specifically about those workshops, then you can talk to me about them then. So I'm going to hand over to Phil now, who's going to start this session. Thank you.
Well, good afternoon, everyone. We're now on session 7, and we're now today going to be looking briefly at PCN finances. And I kind of in bold and highlight the word briefly because I think it could be a topic we could spend days talking about should we choose to. So we've got the usual disclaimer. So obviously this isn't to be construed as advice. It's kind of just chatting around a topic and a conversation. Obviously, if you choose to engage ourselves professionally, then we would back up everything that we do. But certainly in the context of this, it's just general conversation. To give you a bit of background about me, if you've not watched one of these before, I'm a director and an owner of a firm called Mitchells Griefson. We're a firm of chartered accountants. We've been around since the 70s. We're based up in the northeast, but we've kind of got healthcare clients across the UK. And I personally now have looked after GPs for over 10 years and primary care networks since kind of just before they were incepted. So if we think back, we look at kind of the background of PCNs and the primary care network handbook that the BMA and NHS England pulled together. They've been around since 2019, so it should kind of be a bit of old hat really. But we've got to remember that kind of just beginning of 2020, the world kind of became a very different place, and a lot of the things that probably should have been done back then weren't done because priorities, for obvious reasons, changed. But if we think about kind of what primary care networks were, they're supposed to be kind of groupings of 30 to 50,000 patients. We're looking at kind of a 5-year plan. So again, if we kind of think about where we are today, we're well into that 5-year plan. We're in year 3 right now, and they were optional. And optional, we've got an exclamation mark and a question mark there, because I think most people believed they weren't optional and they were absolutely something that you had to do. And there's probably a lot of logic around having to do them, but it was an option at the very outset. You didn't have to participate in a primary care network. So where do we find ourselves today? Well, interestingly, NHS England haven't produced much in new data. So this is from about 2021. So it's not particularly up to date, but it gives you an idea of where we are. So if we go back to that previous slide, we're looking at kind of 30 to 50,000 patient numbers. It seems to be at the higher end of that, the majority of PCNs are registered. There's about 1,250 across the whole of the UK, covering 99% of the population. So despite it kind of being optional, it's pretty much everybody signed up to the DES in the first instance and joined a PCN. So they've been going for quite some time. They've started delivering services, and we're also starting to get a bit of feedback out the other end as to, well, are they doing what we think they should be doing? And there's been a lot of podcasts recently and a lot of kind of press stuff, if you're reading kind of Pulse magazine and things like that, around actually, are they doing what we thought they were going to do in the first instance, and are we delivering on what we think we're delivering? And the BMA have become a little bit vocal, and well, actually, if you were looking to leave, they don't necessarily see an issue with that. So that doesn't necessarily read into whether or not they're all working, whether we have groups that aren't working, but they have been a bit of a step change as to how GP practices are working or looking to work moving forward. And I think that's been a concern for some areas. So we've kind of looked at kind of where we find ourselves in September 22. It's probably worth kind of going back and having a look at, well, do some of the key documents that we're supposed to have in place, are they there, and have we looked to see whether or not they're still appropriate. So every network should have an agreement, and the BMA and NHS England came up with kind of an example document that had some schedules in it. It had some guidance that was sat behind it, and it's a requirement, or certainly at the very outset was a requirement, that you sent your signed version to the CCG, and they would then start releasing the DES money into practices. What most PCNs have done and realised is that kind of initial document was one probably hastily signed up to, because the window of opportunity from kind of this is what we're going to do, this is when you've got to sign up, was pretty narrow. So a lot of practices just effectively signed the guidance document as it was and sent it off without really looking at any consequences behind that or taking any specific advice. But I think what we've started to see now is lots of PCNs looking back at that document, possibly because things have cropped out of the woodwork and practices have merged, or there's been retirements and closures of practices, or changes in who's part of the network, and people have started to look at those documents. What's really important is that the PCN document is a legal document. It is as important as your partnership agreement, and talks about how, you know, everybody should be working together. We're all part of the same journey. We're all wanting to deliver the same across our network. And it's that document that we fall back on if things aren't going to plan. So making sure that we've got that document there and making sure that it is up to date, it is relevant, we have all read it, is a really crucially important part of the network and how it functions. And it's a bit like the partnership agreement. We've done a presentation in the past around partnership agreements. It is one of those documents that you don't necessarily need to refer to every other day, but when you do need it, it's really important that it's there. And you know, getting some good advice around that, you know, speaking to solicitors as guides in those kinds of documents is important. And I think as well, it also, as we see kind of PCNs have changed, if we look back at what your PCN was envisaged to be in April 19, it will be completely different to it is now. If we look at kind of the funding structures that have come through, the type of work that it's doing, there is a lot more that is being wrapped up in primary care networks now than there was even envisaged at the outset. So that whether that document is still relevant and appropriate is unlikely if it hasn't been looked at since then. So if we've got our document in place, if we've got a kind of agreement as how we're going to work together and what we're going to do, one of the big things we see time and time again is how we're managing income and how we're looking at income. And with a lot of monies that are given to PCNs, they're for specific things. So, you know, we've got an example of the investment and impact funding that we've seen this year. So you're given money to deliver certain things, and what we have in the accountancy world is a need to account on the accruals basis, which is about including income in the appropriate periods as well as the relevant expenditure. And if you are given money to deliver a certain project and at your year end, so let's say the 31st of March, you haven't delivered on that specific project, you potentially and more likely haven't earned that money. So it shouldn't be being treated as income. So we can therefore defer some of that income into a future period. Now, if we haven't spent some of that money, we need to identify what it is that we haven't spent. So some kind of simple spreadsheet as the one that I've kind of put on the screen there is a good way of narrowing down, well, actually, what have we received money for? So, you know, a different sheet for each kind of fund that we receive money for, and have we spent it? You know, have we delivered on what we said we're going to do? And therefore, you know, is there a surplus, is there a profit that is remaining on that pot, or actually do we still have some more money to spend? So if we've been given £20,000 or £30,000 to deliver new websites across our PCN, have we delivered on those new websites? Does each practice have a new website? And we need to be able to track, well, of that £20,000, practice A, B and C have done, but practice D hasn't yet, or vice versa. So having, fairly simple, it doesn't, we're not talking about, massively complicated spreadsheets here, but a fairly, fairly simple, and even, in fact, this spreadsheet does have this, but it's not, the page isn't big enough. Underneath that's actually what we're supposed to be spending that money on. Yeah, and is there any time scales to it? Because of course, if you don't deliver on a project and there's a set time scale, you might owe that money back. So that money might have to go back to wherever it came from in the first instance if we haven't delivered on the project, and we're not going to deliver on the project moving forward. So again, if you're offered by the CCG some money to do some new websites and half the practices have already got new websites, well, it's potentially a waste of money to be spending that money on new websites. It may then need to go back to the CCG or whichever funder it's come from. So keeping some simple records is really important. I don't think you need to overly complicate it in that regard, but it is important at the kind of each year-end point of your PCN, understanding, well, what have we not spent? What have we got left to spend? So you don't want to underspend on money either. So if you're given, again, £20,000 to deliver some projects and you've not done it, well, potentially it's a waste of money to be handing that back. So what do we need to do to deliver on those projects? So I said I'm a big believer in keeping it simple, and that is kind of one of those ways. Something that's not simple and can't be easily kind of drifted across is VAT. And VAT is massively complicated at the best of times. It's even more complicated when you roll primary care networks into the mix and suddenly realise that NHS England and HMRC have never talked about this ever before, and there's no real clear guidance. So the main bit of guidance that is fully published is from 2014, which, if we remember, that kind of first slide is well after when PCNs have come into existence, and it talks about healthcare in general, yeah, and how that healthcare works. And it's all about the prevention, maintenance, restoration of individuals' health, and also talks about registered lists and health professionals being on those lists and delivering care within those lists. And actually, one of the questions we got kind of this afternoon session talked about was actually, well, what do we do about VAT and how does it work with regards to individuals in delivering their service? And that there's a couple of challenges that PCNs need to get their heads around. Is one, are we delivering healthcare? And that might sound like a flippant response that, well, yes, we are. We're all part of the NHS family. The VAT Office are a little less friendly when it comes to who is in and who is out of our family. So the challenge that a lot of PCNs have is that a lot of their staff, the ARRS type roles, don't necessarily fall within the healthcare provision. So if we've got things like nutritionists or something like that, that are social care type workers that might not necessarily fall within some of the lists that the revenue recognise, you may not be considered to be delivering healthcare, although staff may not be seen to be delivering healthcare. And the other thing that we've got to be careful of as well is even things like a clinical director, and one would have thought clinical in the title would be a bit of a clue, but actually is what is that person doing? So is that person delivering care, or are they delivering the management of the care, and how is that being done, and how is that person being employed? So there's a lot of complication around primary care networks and VAT, and what we even say to our primary care networks that we look after is that you need to take some specific VAT advice on your specific circumstances. Because if we think back to our agreement and the original BMA handbook, there is 5 different ways you can set your PCN up, and there's then about 1 million ways those 5 different ways can then operate. So depending on how your circumstances are being run, how you're employing your clinical director, how you're employing some of your ARRS staff, staff? Are you interlinked with a federation or another kind of third-party NHS type grouping? Can have a big effect as to how that VAT should be and will be accounted for, if it's at all relevant. So it's definitely worth spending some money with a VAT specialist who understands that. If anyone would like me to kind of pass any contact details, I'm more than happy to do so. But it is a very complex area that needs a bit of attention, especially when you think of kind of the numbers that PCNs are dealing with now. We're not talking about 20 or 30 grand of income. Certainly of the PCNs that we look after, you're talking of millions of pounds of income. So getting it wrong can be potentially quite expensive. The other area which again is causing a potential lot of heartache for primary care networks is staffing and employment, and how we are employing these individuals. And again, there was 5 different ways that primary care networks could be set up per the original handbook, and 101 different ways that we can employ people to do that that way of working. A lot of the employment challenges come around, well, are they employed in the first instance? Who is the employer, and how is that cost being shared amongst the primary care network? Because if we think about kind of most primary care networks aren't entities in their own rights, so they can't really employ anyone because there's nothing to employ anybody. So people end up being employed by the member practices. Well, that causes potential issues with just general employment law. So if you've got somebody employed by practice B who's working in practice C, well, who's responsible for that person? Who's responsible for the health and safety and the care and well-being of that person? If that person is then being employed, going into practice C on a Friday and gets bullied by another member of staff, well, who's responsible? It becomes very complicated. There's also a lot of HMRC challenges around that as well, about the recharging of staff members, and also things like the workers' rules as well, about, well, how should those people be taxed? So a bit like when we had CCGs a few years ago, kind of overnight employed everyone because the revenue said, no, you can't just give cash to people and hope that they pay their taxes appropriately. You should be putting them on the payroll. There is, concern around that as well. And again, HMRC and NHS England haven't given any written guidance as yet as to how that should work. So if you have a look on HMRC's website for the employment toolkit and the employment checklist kit, that should allow you to kind of go through each circumstance of where you're engaging with people. How should they be working for yourselves? And again, it would be wise to take employment advice along that route as well, that if all of a sudden you're starting to employ a number of people, if practice A is employing 20 or 30 individuals, is practice A covered for any liability points of view? Should we have redundancies? If said it's a 5-year contract that will be expiring in relative terms, not that long. We don't know if yet it'll be reviewed, so we could potentially have 30 or 40 people being made redundant at the end of the contract if there's nowhere else for them to work within the organisation. So if we've got that, there's a lot of potential liability, and who does that sit with? Well, I'm quite certain practice A wouldn't want it, and it should be probably shared amongst everybody. But again, what does the agreement say? How are those people employed? Are they employed in the right manner? So there's a whole kind of raft of things we could have talked about this afternoon, but we've only kind of had 20 minutes, half an hour to kind of run through things. But what I thought, as we're doing at the end of each of these sessions, would be sensible to kind of open it up to any questions. So feel free to kind of put them in the chat box if you haven't already. If you've got anything you want me to specifically look at. We did have a couple of other questions that kind of came in prior to this session. Almost around kind of the longer term budgeting for primary care networks, given that the income isn't guaranteed. Yeah, you can't budget really beyond that point. And what we've seen over the past couple of years is an awful lot of funding being moved into primary care networks that hasn't been before. And it's almost budgeting on an area of funding. So I mentioned before, kind of £20,000 for websites. You're almost funding and budgeting around that fund rather than kind of the wider picture of where do we find ourselves, because unless anything's been released in the past kind of 48 hours that I've not picked up on, we don't know what's going to happen at the end of year 5. Now, one would hope they're not going to pull all of that money out of primary care, but it doesn't necessarily mean it's going to be continuing in the same manner that it is at the moment. So I think a lot of networks need to be focusing on, well, the delivery of the projects that we've got and budgeting around the funding that they've got so far. And it's relatively short term, unfortunately, until we get some more reassurance about the future. So someone's also mentioned about practice managers becoming partners. There is actually another session like this that we did previously around that. So if you have a look, I think they're on YouTube. If you have a look on YouTube, you should be able to find the previous 6 that we've done. And I can't remember the number it was, but there is one we've talked about that separately. And then someone else has asked the question, is kind of along the same lines as the first one. How does the transfer of finance to general practice work from the CCG to general practices as we are just taking over another practice? So I presume we're talking about kind of the merger of a practice with that funding. And I think actually the next seminar we're going to do is going to be on practice mergers. So we'll absolutely pick that up and talk about kind of how that will work in the next session when we're looking at practice mergers. But if you've done something specifically about PCNs, by all means ask again in the chat, and I'll happily provide that. And I think the final question that we had was kind of picked up in the slide about employment, which is just what do we need to be aware of if we're employing non-clinical staff on behalf of the primary care network, and then doing work among several practices, and they've used the example of social prescribers. So absolutely, it's not necessarily just non-clinical people. It could be a GP that is doing something that is not for the benefit of somebody's health. So again, if a clinical director is organising meetings, as a good example, well, can we argue that is going down to delivering and caring for an individual's health? HMRC might have a different view to what that clinician does. So again, some caution needs to be thought around that. And then how are other similar, so that they've also gone on to say that their PCN is becoming a limited company. So that is certainly something that we're seeing quite a lot of at the moment, because it removes that challenge of you're not a real entity. Yeah, you become a limited company, you then are an entity. That gives some structure. You can start employing people, etc., etc. If you've got that kind of structure to it, you've got those people that you can then get employed. You then potentially have that. Well, how are you going to look to distribute that income back to your member practices, if that's the kind of general drive of travel in your PCN? It will depend upon what's in your agreement. So if your agreement has in as to how the mechanisms are going to work, how your members are members, a lot of them, and I'm kind of speaking generically around this, is linked back to your list size. So if practice A has 5,000 patients and practice B has 10,000 patients, they're entitled to more of the surplus than the previous. And then generally, if it's set up as a limited company, any surpluses could be, emphasis on could, be refunded via potentially dividends back down to members. But it really does depend upon what is in that agreement that you're all signing up to as part of the incorporation of that limited company. So it is important that if you're moving into a limited company structure, you get that independent advice from either your own accountants or from a lawyer or somebody like ourselves around, well, actually, what am I signing up to, and what are the ongoing implications of that? Yeah. I think that there is a couple of other questions that people have just dropped into the chat there. Yes, the first question there about a copy of the slides. After today, we'll pull together a bit of a workbook that has the slides in bits and pieces like that. I said, if you want to solve insomnia, you can watch it again as well in a couple of weeks' time when it's put up. Yes, my contact details are in the slides, so I'll move on to that slide. So there's that slide there. Yeah, and Catherine said there, we're going down the limited company route. Seems the only sensible way to be able to continue safely in today's NHS. Yeah, I think there is a lot to be said about going down that route. I think my only caveat with the limited company route is if things kind of stop at 2000 at the end of that 5 years and the funding disappears, you could have had a lot of time and effort in getting to that point for it then to be all disbanded. But, you know, thinking kind of logically, I can't see the rug being completely pulled because a lot of effort's gone into primary care networks, and one would assume that they don't go down that path. So no, I would agree, having that limited company structure adds some structure to what you're trying to achieve within a PCN. Yeah, so the next question is kind of interesting to understand how the PCN work with funding and finances. Yeah, it's a topic we could spend a couple of hours on, and we do in the course that Helen mentioned at the outset, talk a lot around that and about how it kind of comes through, how it properly works, to try and squeeze in over the course of a cup of coffee. How that would all pull together would just be a bit challenging time-wise, I'm afraid to say. Oh, and Helen's put some links on to where you can sign up to those courses, should you choose. So that's probably everything, unless anyone has any other questions, or if anyone wants to drop anything into the chat. You've got my contact details there as well if you want to get in touch with myself. But if there isn't anything else, thank you very much for listening. And I think I've put on the previous slide there, we do have a couple more presentations lined up, practice mergers and limited companies. But if there is anything else that anybody would like us to touch on, by all means, kind of get in touch with Helen or myself, and we'll look to pull that together. Yes, so there is a lot of talk around the money laundering rules and PCNs and whether or not they should be registered. There isn't any guidance, which is kind of the theme of today, really, isn't it? That we've had all of these good ideas. So if anyone doesn't know what Christine's mentioning there, the money laundering regulations have been around for a long time to prevent people from laundering money, and there was an update earlier last year which is coming into effect now with regards to trusts and whether or not trusts should be regulated and registered with HMRC to try and avoid money laundering problems. The trouble is that the word trust is a very open term and encompasses a lot of things. So one of the concerns that LMCs are kind of highlighting at the moment is whether or not PCNs are caught within those rules. The trouble is there is no guidance as to whether or not lots of things should be caught with those things. So because trusts is a very open term, the guidance is a bit wishy-washy in the nicest possible sense. The general consensus is that if you are set up for commercial reasons, there is an exemption that means you don't need to register because a commercial body will be reporting it elsewhere. There's also concern that kind of drifts away from what we're talking about today, but around if you hold your property with more than 4 partners, so you can only register a certain number of partners at the land registry, and if you have more than that number of partners, which from memory is 4, then effectively the other partners who are registered at the land registry are holding that property on trust of everybody else. So again, is a trust being incorporated in those circumstances? Again, it's likely not to be the case because that's probably not what the money laundering rules are trying to intercept. Because those properties are being held, they're being reported in partnership accounts. Partnerships are already registered with HMRC, so there's nothing happening out with of HMRC's knowledge, which should be the same with PCNs, because again, PCNs are commercial entities. The information should be being reported within practices accounts. Therefore, it should be caught by the exemption of a commercial body, but they've not confirmed either way yet. So the Institute of Chartered Accountants, of which we're members, is petitioning HMRC to understand whether or not can we come up with a more comprehensive list of what falls within that. But it is something that you may want to kind of just keep an eye on in case anything comes out over the next I'll say months rather than weeks. No, perfect. Well, again, thank you very much for your time. I hope it's been useful, and hopefully see you next month, if not before. So thank you all very much. Thank you.